All right, blood volume. So, yes.
So the way to really differentiate between these two is looking at like the CT or the MRI.
Yeah, CT, MRI is very, very specific to look at changes in cerebral edema, whether it's cytotoxic or it's vasogenic, and they can kind of tell by the diagnosis. So if it was a stroke, it is going to be cytotoxic, right? If it's a tumor, it's probably going to be vasogenic, or if it's a like a traumatic brain injury, for instance, it might be a vasogenic edema. So knowing the mechanism of injury is important to figure out what kind of edema it is and what kind of therapies to give. Like we mentioned, steroids. One gets steroids and one doesn't.
CT CO2 monitoring, like on the house.
Yeah, end-tidal CO2 monitoring, pulse oximetry, glucose monitoring, all those things we do to maintain good ICP. And we know why the ICP would go up in those situations because the CO2 is climbing or the oxygen is dropping, right? Those are all things that would key us in to, to intervene early if we need to. All right, so we talked about brain, right? So now we're talking about blood. So the blood volume in the brain is going up. So not CSF, but our blood. Because we know we have a certain amount of CSF in the brain at all times, right? About 10% of it is CSF. We're talking about the blood volume itself, right? So the blood volume could go up because someone has a hemorrhage of some sort, right? The hemorrhage is developing, the hemorrhage has extended into the ventricular system. That's not good because now that's where my CSF's at. And I know my CSF's like a little highway. It's made in the lateral ventricles right here, and it then goes through the whole body, or not whole body, the whole brain, and then it gets reabsorbed at the top of the brain. So if I'm blocking the flow there, now my CSF's at risk of going up, right? But now let's go back to the blood. So blood volume is going up in some fashion. And all this blood developing, and depending where it's at, next week we'll talk about the different types of bleeds. I've got an intracranial hemorrhage. These are all intracranial hemorrhages because they happen in the cranium. And I have intraparenchymal hemorrhages, which are IPHs, where you have, it could be a, intraparenchymal, like a bleed around the basal ganglia or thalamus. It could be a pontine bleed. It can be in any lobe, really. And then, actually, I backtrack, intracerebral hemorrhage. So usually ICHs I confuse because it's intracranial, intracerebral, which one is it? So you have all kinds of different varieties. You have hematomas, subdural, epidural. You have hemorrhages that can occur in the arachnoid spaces, in the ventricular spaces, intraventricular hemorrhages, subarachnoid hemorrhages, and we'll kind of elucidate those a little more next week when we talk about all kinds of different kind of hemorrhages, right? So we have like a hemorrhage that's an epidural hematoma. There's a subdural hematoma, right? We have an intraparenchymal hemorrhage, which is in the parenchyma, which is the working part of any tissue, right? The parenchyma of the kidneys are the what? The nephrons, right? So then the Nougat center, that's the adrenal medulla, right? So then we have the parenchyma of the brain is the gray matter or white matter?
It would be white matter.
It'd be gray matter. So gray matter is where white matter is the myelin sheaths, right? The gray matter is the actual operational neurons, right? So we have our, that's our parenchyma. So we have an intraparenchymal hemorrhage, and obviously it's going to disrupt function in that area, right? So we have subdural, epidurals, we've got subarachnoid hemorrhages, usually happen from aneurysms of some sort, is common, or trauma. You can have bleeds on top of the brain. These are not going to really cause a lot of problems, right? Cap it, suck it an am, right? So you go suck it an am, right? So it's going to be that's the one that crosses the suture lines, right? Versus a cephalohematoma doesn't cross suture lines. You should see that in like newborns and such, but it can happen with a trauma patient too. But once we start getting into the cranium, an intracranial hemorrhage, then we have pretty much now we're at risk of an epidural hematoma or a subdural hematoma, starting causing herniation syndromes, right? Depending on where it's at. And is it worse if it's on the in the cerebrum or in the cerebellum, in the basement there? Which one's worse? The cerebellum, right? Because that's a very, very enclosed space, right? That's definitely going to raise the ICP to the point where it starts compressing the brainstem. All right, so we got a hemorrhage into the skull of some size. All right, so how did it get there? I don't know. It could be trauma. That's usually easy to explain. I got a trauma, intracerebral hemorrhage, subarachnoid hemorrhage, subdural, epidural. That's pretty easy to explain why my ICP is going up, because I have this volume of blood that has increased due to a trauma of some sorts, right? And any trauma to the brain is called a traumatic brain injury, whether it just be a concussion or a contusion, all the way to a diffuse axonal injury, which is the worst case scenario. Any kind of bleed in the brain usually is a traumatic brain injury if trauma was the source. Because you can also bleed in your brain if you have a vascular problem, right? I have a vascular bleed of some sort. I got a hemorrhagic CVA, which we'll talk about next time, right? That's 13% of your CVAs, is the most deadly one. And then we have a large ischemia large ischemic stroke, which is 87% of your strokes. And are they as bad? They are bad if they are huge. If it's a huge ischemic stroke, it can easily have a hemorrhagic conversion. Right? That's one of the complications of ischemic strokes is a hemorrhage is the worst case scenario. So that's why we could have a bleeding into the brain, right? Aneurysm can be traumatic or it can be just due to hypertension. Hypertension causes ischemic and hemorrhagic strokes. So hypertension is a key piece to fix on the outpatient side. Also on the inpatient side, we talk about blood pressure control next time. You want to get your blood pressure, within certain ranges. So whether it's ischemic with TNK or whether it's just plain ischemic or whether it is a hemorrhagic stroke. And knowing the last known time well is important in that management. Right? And then we got a hemorrhage that can happen due to a vascular issue, right? So we have a hypertensive bleed into the thalamus. And the thalamus is just lateral to the the lateral ventricles there. It's actually, sorry, it's just lateral to the third ventricle right there. So there was a good picture of it. Third ventricle is like right over here. But anyways, we have that can then bleed into the ventricles of the brain, all right? And then that's now obstructing CSF flow. So we got blood where it shouldn't be, right? Obviously you don't want blood in the brain in the first place, but if it's now leaking into CSF areas, we're going to obstruct CSF flow. We know we can't turn off the CSF faucet. It's always producing CSF, like about 25 mLs an hour, about 250 per day, or 250 to 400 or so. All right, so blood volume, CPP and CBF. So CPP is cerebral perfusion pressure. So as we mentioned, you have a map. All organs get a map, right? The kidneys, the liver, the heart get a map delivery, and it's then the tissue to be able to receive that. So like on the kidneys, if you're fluid overload, the kidneys have to offload fluid, right? If it can't offload fluid because your CPP is so high and you're so fluid overload, its renal perfusion pressure is going to be very, very low and it can die. Same thing with the brain. We have this, but the kidneys aren't encapsulated by a skull, by a bone. They can be encapsulated by a belly that's really big, but they are encapsulated by a huge skull that's in the way, right? And we have that intracranial pressure that's pushing back on the delivery of blood. And how much did it came out? Well, that's going to be our CPP right here. That's the cerebral perfusion pressure. What ended up getting delivered to the brain was our map we gave it minus the pressure on the other side, right? So that's our cerebral perfusion pressure. You want that greater than 70. Some sources say like 70 to 100, but greater than 70 is what you want. And sometimes you can't always measure the ICP. You can't always have a ventriculostomy or EVD in there to measure your ICP. You just got to kind of estimate it. So if they have a huge, huge bleed, you could say it's probably like 15 to 20. That's a big, big ICP. And also you kind of look at the symptoms of the patient and everything. If they're having a headache all the time, they probably have a higher ICP. So, having a map of 65 is not going to cut it, right? Because 65 map minus a ICP, let's just say 10, is a CPP of 55, right? So is that going to cut it? No. Yes, the brain can survive at 50, but we don't want to be playing around with that. We want to make sure we're delivering as much blood supply as needed, right? So that's the idea behind the perfusion of the brain. The perfusion of the brain is the map minus the ICP. Okay, so decreased CPP, well now you have decreased O2 delivery, and decreased O2 delivery is going to raise the ICP because now we have cerebral edema again, right? So also, of course, glucose is also involved there, and that's more cell death, more cerebral edema, and more drop in the CPP. So that's a cycle we want to abort at some point, right? We want to make sure we're providing good blood flow to the brain. Okay, so we provide a cardiac output, a little map, a little CPP right there. We're providing it to the brain. The brain has vessels in it, right, as we know. And if someone's super vasoconstricted, why would they be vasoconstricted? So if they were like hyperoxic or hypocapnic, like we're trying to work overtime to lower someone's ICP, right? We're ventilating them really, really strongly, right? We can vasoconstrict to the point where there's no flow to the brain. That's why I gave you that number of 28, right? Once you start less than 28, you're going to vasoconstrict to the point where there's no flow, right? On the opposite side, if we vasodilate, yeah, that will improve CPP or improve MAP a little bit, improve flow, but that might increase the ICP in the brain. Okay, and of course on the other side we have to drain. The CSF gets made in the middle and it gets absorbed and it drains down into the jugular vein. What if my jugular vein is occluded because I have my neck not midline and my neck's closed? That's going to then back up, right? CVP as well can back up. Also just straight up abdominal pressure or thoracic pressure can all translate up into the brain. Okay, so we got to maintain a good CVP and make sure a good jugular vein drainage. Otherwise, that can impair the flow that I'm trying to deliver to my brain, right? I'm trying to deliver on this side, and I got to make sure that the CPP is adequate, right? What else can do that? Well, what if I have, I'm delivering just enough MAP, 75, 80, let's say, but then the oxygen demand is super high. So my cerebral metabolic rate is really, really high. The brain metabolism is super high. That means that MAP of 75 is delivering, let's say, 250 mLs per minute of oxygen. That might not be enough for the brain. It might be requiring a lot more oxygen. Well, usually DO2 is about 500 to 750, right? And if the volume of oxygen that the brain is using at all times, like 300, 400, because they have a fever or seizure activity, that you might not be able to meet the demand. So we need to make sure they're getting enough oxygen at all times. Okay, so cerebral blood flow, right? So that is what is our perfusion, right? It's the flow of blood in the brain, right? So we have cerebral perfusion pressure, but then we have the vascular resistance of the brain, right? Just how we have SVR for systemic vascular resistance, we have pulmonary vascular resistance for the lungs that puts extra stress on the right ventricle. We also have, cerebral perfusion pressure, cerebral vascular resistance. So what we deliver to the brain is dependent on the vasoconstriction or vasodilation of those vessels. And our brain's really good about it. It does what's called autoregulation. It can adjust that at all times. If the brain's hypoxic, it knows automatically to start vasodilating, because it knows if I vasodilate, I'm going to reduce the pressure it takes to get into the brain, or the resistance, and that's going to improve my flow. Right, so it's very good about this. It does the same thing with CO2. It does the same thing with pH. It will adjust the flow automatically based on the hemodynamics of the brain. Okay, it's called cerebral autoregulation, cerebral vascular resistance. They can change on PCO2, O2, changes the MAP, changes in the metabolic rate of the brain. It will adjust accordingly and will vasoconstrict, vasodilate at will, right? And it's instantaneous. Just like our pulmonary vasculature can know that it's hypoxic upstream, it can automatically go backwards to time, and it can actually vasoconstrict in the lungs, but in the brain, it vasodilates, right, to allow better flow. All right, so this change in vessels can maintain our flow to the brain at all time. And we need a flow of at least 50, right? Is that a CPP of 50? Well, we don't know what the resistance is, so that's why we have the CPP just a little bit higher. Okay, so normal MAP, definitely greater than 60. I'd probably even do 70 plus. And if they have hypertension, even higher. They're usually used to a higher blood flow. And then ICP, 0 to 20, if you can measure it. Otherwise, we're kind of ballparking it, depending on how bad the insult is to the brain. And CPP, definitely greater than 70, right? If I have a MAP of 60, I can't get a CPP of 70. That's impossible, right? Even if the ICP is 0, I'm not going to be able to get a good flow.
So, like on an intracranial hemorrhage, is it better to ride the BP higher just for the extra MAP?
No, intracranial hemorrhages, no, you still want to get, because if you have a hemorrhage, you can actually push through the vessels, right? And you can actually, yes, you'll improve your blood flow, but all that blood flow will actually leak into the periphery, right? Into the blood, into the brain, right? So you want to have a controlled blood pressure. You don't want the blood pressure to be too high, otherwise it will start oozing itself through the vascular damage.
Like parameters, it would be better to ride the parameters higher.
No, a range of blood pressure targets is usually what we look at. So 140 to 160 is for most hemorrhages, right? So would you prefer 140 versus 120? Not really. So I mean, you could argue with like hypertension, for instance, someone with normotensive, they don't have that extra buildup of scar tissue and tissue for the vasculature that's been under duress for 20 years from hypertension. So they might want to have a little higher target. 160, right? Whereas someone normal, you don't need to have that, right? 120 or 140 to 160 is perfectly fine for a blood pressure target. Okay, so autoregulation is a little bit more on that, right? So your vessels are getting bigger versus smaller, right? Based on changes in my CO2, my MAP, and my PO2. If my PO2 is really, really low, I'm going to start vasodilating really quick, right? So I'm going to vasodilate as soon as possible. And again, it does this based on the MAPs and the O2 levels out in the periphery, outside the brain, but also has all these regulations, or these chemicals that are flying around that work instantaneously in nanoseconds to vasodilate as quickly as possible. As soon as it detects O2 is low here, it automatically sends a signal back in time to vasodilate, right? So CO2 dilates, and if it's dilating, that can increase the ICP. So as we can see, with elevated CO2, it's going to start it's going to start causing vasodilation, and to the point where we can't really control it, right? Because we can't fix the breathing. We're going to try to fix the breathing. We're going to try to make them breathe faster, but sometimes they took a medication or a respiratory depressant that impairs that, right? So that's why sedatives should be avoided, right? Avoid hypoventilation, avoid acid buildup, because acid is what CO2 is doing when it's building up. When CO2 builds up, that's a buildup of which acid? Of our carbonic acid, which got cut off there. All right, but carbonic acid gets built up with CO2 and water, right? And sometimes we allow permissive hypocapnia, but it's only like, you only got like 3 strikes on it, or 3 to 5 shots to lower someone's ICP with hypocapnia. Otherwise, in the meantime, you should keep the CO2 about, on the lower end of normal, 35 to 40, 35 plus or minus 2 or so, right? And again, it lasts about 6 to 8 hours at best. And if you drop the CO2 less than 28, it can cause a vasoconstriction like nobody's business. It's going to vasoconstrict to the point where there's no flow to the brain. So that's why we don't overdo it in that case. All right, PO2, 50, that's what was recommended, but I really would target like 70, right? That's kind of be a better target because we went 92, 94%, and we know SAT 90% is PO2 is 60, so definitely more than 65 for sure. All right, so I'll probably say 65-ish, right? 65 plus. And then, as we know with hypoxia, that's going to disrupt the membranes and cause cerebral edema. So we want to make sure that we are avoiding dramatic drops in O2, because that will lead to lactic acidosis, apoptosis, lack of cell membrane integrity, cerebral edema, and that will ultimately increase our ICP, right? And then lastly, MAP, right? MAP is 60 to 150. All right, 60 again is probably in the low range. I'd probably like 75 to start with, especially if I have a good injury to my brain. I'm going to keep a MAP at least 75 because I know the ICP is probably a little bit high to be impairing the flow of blood to the brain. Okay, so decreased CPP is going to lead to your body's going to start vasodilating as the blood pressure starts going down, the MAP starts going down. It's going to start vasodilating and vasodilating and vasodilating, so it allows more blood flow into the brain. That's what it does automatically with hypoxia and also with a drop in MAP. On the flip side, if we have too much MAP, your body's going to start vasoconstricting in the bloodstream, in the brain bloodstream, and up to the point where the MAP is just high enough and it can overcome the vessels themselves. It's trying to vasoconstrict, but the increased pressure can actually push aside and open up those vessels, and that's where we got that little vasodilation at the end there. Right? It wasn't because the brain wanted to do that; it's because it got pushed open by such a high blood pressure. Okay, so that's a MAP greater than 160. The brain is definitely not able to compensate. Okay, so cerebral metabolic rate. All right, so the metabolic rate of the brain, as we mentioned, you have a fever, you have increased O2 demands with a seizure activity. These are things that are going to stress meth use. Please don't have your family give meth to your patient. All these things are going to start increasing the O2 demand of the brain. So we provided a great MAP to the patient. We provided great O2 and CO2 levels. pH is normal, but the patient has a fever. So you can provide that MAP of 75, but they require a lot more oxygen. That 75 MAP might not deliver the oxygen they need, right? And now they're at a deficit, right? So that's cerebral blood flow we deliver to them has an O2 arterial content, right? The cardiac output, the hemoglobin concentration, the PO2 saturation, all those things, but that O2 delivers on this incoming delivery is not enough for the brain. So we got to reduce the brain's consumption of oxygen, right? We got to start making them less wakeful, right? We got to make sure we start shutting down the brain a little bit so that it's not using so much oxygen. Okay, so utilization of oxygen in the brain, yes, to cerebral blood flow, but the metabolism was what we're focusing on. They got stress, they got seizures, the temperature is elevated, the glucose and oxygen levels are not what they need, so that's going to cause an increase in metabolism. So how do we know? What can we do to fix ICP that's intractable? And what does intractable mean?
Is it like malignant?
Malignant, yes, but it's ICP that you cannot fix. Like intractable vomiting is vomiting you cannot fix. Right? You gave an antiemetic, you gave Reglan, you gave ondansetron, you gave erythromycin, you gave all the things to fix someone's nausea, but they're still doing projectile vomiting like The Exorcist, right? And that's usually when we have intractable vomiting, that's usually ICP. That's until proven otherwise, right? Or like intractable pain in their leg that you gave morphine for, that's probably compartment syndrome, right? So intractable means something you try to treat, but it's still there, right? So really, really high ICP elevations. What can you fix? Well, fever is one, right? We can do TTM, which is targeted temperature management, where you are going to be now in charge of the temperature. You're not going to let them get febrile because now you have pads on them that are always going to externally cool them to whatever temperature you set, right? We know we don't do hypothermia anymore, but we might choose to target like 36 degrees Celsius, right? Control seizures. We'll give anti-epileptics, especially if they have cerebral edema, not due to strokes, but cytotoxic edema. Your vasogenic edema. And then we have permissive hypocapnia, right? We'll allow the CO2 to be at 30 to 35. We might even, we only got 3 to 5 chances of bringing that down. Maintain everything normal, right? Eutension, I probably, might have a little target, a little higher map, right? And then I have metabolism, even more can be suppressed. Propofol can start shutting things down so that you're reducing the amount of oxygen requiring processes in the brain. And then we have barbiturates. So barbiturates, as you can see here, we got propofol, benzos, opiates, I put prop in here as well. They are cutting down the cerebral metabolic rate. They're reducing it, right? So you have all these things. You have, of course, meth and nitric oxide are going to raise it. Ketamine will raise the consumption of oxygen. But our propofol and all the other guys are going to reduce the amount of oxygen demand overall, right? Whereas barbiturates here, oh, there's prop right there. So barbiturates, though, they are going to literally shut off the brain. Right? You're not playing around anymore. It's like we need to shut everything off. And it's literally that you're just pulling the plug, not on the patient, but you're pulling the plug on brain metabolic processes. Right? Absolutely, the brain is now going to shut down when they're on barbiturates. Right? And then how long does that last? Propofol lasts about 10 minutes. Right? You turn off propofol, it's done. What happens when you turn off the barbiturates? How long does it last? If you give an infusion of barbiturates, an IV infusion, it's going to last for 4 days. All right, so the half-life of barbiturates are at least 4 days. Right, so take at least 2 to 3 days to get them back up to normal again, to reboot them. Right, but it's going to shut them down. It's going to definitely shut down all these processes and reduce our metabolic rate for sure. Right. How many times have I seen this? Probably like twice in the last 16 years, where we actually had to pull the plug. Not pull the plug, but yes, I guess pull the plug. We were going to actually, pull the trigger on giving barbiturates, right? That's really a rarity, right? You're seeing ICPs that are going up and up and up, and then we have to then, give the barbiturates to cut everything off. Okay, so our goal is to stay on this plateau of regulation. If we fall off by increasing the pressure too much, or decreasing the pressure too much, or decreasing the oxygen too much, or increasing the CO2 too much, you're going to fall off this curve right here, which is what you want. What you don't want. You want to be right in the middle, so we are not going to, get into trouble, right? So MAP 75, everything else normal. It's basically it's easier said than done, though. Okay, so there could be a cascade of vasodilation problems and a cascade of vasoconstriction problems that we can run into. So basically, if you keep everything normal, then we shouldn't run into those issues. Okay, and then ICP elevation is our last thing that will reduce cerebral blood flow. So if I have a poor map, the fact that I had this poor map delivery, if I start raising the ICP, that's going to definitely worsen it more, right? It's going to worsen the blood flow even more. And of course, we know the CVP needs to be good. All these things we're interacting with to try to fix. Okay?
Sorry to interrupt. Can I get a communication board, Aaron? I think it's in that file cabinet.
Okay. So metabolic rate is what you want to be fixing and reducing on someone that has a increase in the ICP. All right. So what's the causes of all these things? It's going to be your CSF volume going up. It's going to be your brain volume going up. It's going to be your blood volume going up, or some other things. You developed a tumor. You develop an abscess, right? You can't really, we can take it out, the abscess. We can take out the tumor to relieve someone's increase in their ICP. They can have a parasite infection, like this patient right here, who did not survive. This patient had neurocysticercosis. It took like 3 days to master that. Right? It's really fun to say when you're in the shower, neurocysticercosis, right? But we had a patient diagnosed with that, and nobody could pronounce it. But that's where you have this parasitic infection from undercooked pork, right? Or who's having pork tacos tonight? Anyways, we have a increase in ICP is definitely going to be one of these 3 things, and of course a 4th thing being introduced, such as a mass of some sort, that can definitely raise our ICP even more, right? So we're looking at CSF volume, which we'll be touching on coming up after our next section there. And that's where you have the volume of CSF we can't drain it, it's an easy fix, or we have a buildup because we have blockage of flow of CSF, right? So jugular venous drainage, or we have hydrocephalus that's developed, a fluid on the brain, not because of cerebral edema, but because it's swelling because the CSF can't get out. It's like you want that to be constantly coming out. If it can't, it's going to start backing up and raising the pressure in the brain. Okay, and as we mentioned, your abdominal cavity, your thoracic cavity, all these things can back up and impair jugular venous drainage. And then what else? You got brain volume. It could be a mass like below, but definitely we're looking at edema. We've got a huge CVA that converts over to a hemorrhagic CVA. We got global damage to our brain. All these things are causing a dramatic increase in our ICP because it's raising the volume of brain tissue, right? 80% of our brain of our ICP is due to brain tissue. So if we just changed the edema concentrations a little bit, or edema amount a little bit, that can then lower our ICP hopefully. All right, and brain volume, blood volume, we mentioned an intracranial hemorrhage of some sort, whether it be a venous bleed like a subdural hematoma, or arterial bleed like an epidural hematoma, or intraparenchymal hemorrhage, or whatever it may be. These are things that are causing a increase in our our blood volume within the brain. And we know about autoregulation. The vasodilation or vasoconstriction can be changed based on the amount of hypoxia we have, right? If we get more and more hypoxic, that causes more and more vasodilation. So why even deal with that? Let's back it up and keep the oxygen normal so the brain doesn't automatically autoregulate to vasodilate. Okay, so that's the idea. We have this critical area where we have to fix these problems to avoid the dramatic rise in ICP. And again, it's exponential, right? It can be a slow developing bleed or a very, very fast growing bleed, and it can start compressing different things that we've been talking about, right? The cranial 3 can be impaired, right? It can start raising the pressure in the brain, causing an increase in the ICP, which can lead to headaches. It can start compressing the chemoreceptor trigger zone, causing emesis, causing vomiting and such. Okay, so that's the idea behind our ICP elements: volume, brain volume, blood volume, and CSF volume, and then of course some other things that can develop tumors, etc.